Well, good morning, everybody, and welcome to the Surgical Grand Round today. And it's a great pleasure to introduce my colleague, Professor Puneet Plaha. Puneet trained in Bristol and has been a consultant neuro-oncology surgeon here in Oxford since 2012. He's the lead of the neuro-oncology MDT in the Thames Valley Cancer Network for brain tumours and chairs the neuro-oncology section of the Society for British Neurological Surgeons. He has a specialist interest in endoscopic, minimally invasive surgery for brain tumours, for which he has developed new techniques. He also has extensive experience in awake brain tumour surgery and has established advanced techniques for this too. Puneet leads the Oxford Surgical Neuro-oncology Research Group, which investigates novel surgical modalities aiming to make brain tumour surgery safer. The group's also engaged in work on brain tumour immunotherapy and in clinical trials for brain cancer, and notably is presently the chief investigator for the multi-centre UK NIHR-funded Future GB trial for glioblastoma. Before I hand over, I just remind everyone just to turn cameras and microphones off during the talk. We'll take some questions at the end if there's time. Over to you, Puneet.
Thank you, James, and NDS for the invite. It's my second talk after many years. And I thought it's a good opportunity to just talk about the work which has happened in Oxford over the past 10 years with our group and where we are 10 years down the line. So I've sort of titled it Changing Face of Brain Cancer over this period of time. So I've broken down my talk into a few things. I've chosen glioblastoma, which sadly is terminal brain cancer. And I thought I'll start by talking about our change in approach in managing these tumors, how this led on to an NHR-funded Future GB trial, which is presently running, where the limitations with managing brain cancer are and how we've addressed this by looking at some of our work on Raman spectroscopy and mass spectroscopy. Then there's a recent new trial, which is a good example of going from bedside to bench with Combat GB, and then where the future holds with a further trial when there's sadly a recurrence with these cases. So glioblastoma is a common brain cancer in adults. The incidence is quite low. It's a disease of the elderly, more common in males than in females. If you look at the overall survival of glioblastoma the past 2 decades, there had been slight improvement, but not very much. In the clinic on a day-to-day basis, we still quote figures of median survival 14 to 16 months and only a 10-year, 5-year survival. We looked at the National Cancer Registry and published this paper recently to look at the changing trends, and not much changes with glioblastoma sadly over a period of time. Now, I chose this paper. This is a New England Journal paper in 2005, a 500 plus randomized controlled trial looking at how radio and chemotherapy could change the outcome. And the reason I put this up here, because this trial was done 20 years ago, and the data for this trial still dictates the overall survival, what we discuss with patients in the clinic. So there's a lot of work to be done. Now, just briefly, what glioblastoma is all about. Following the diagnosis, surgery is the mainstay, followed by radiochemotherapy, and sadly, there's a recurrence. And I'll talk you through how things have changed, certainly in Oxford, over the past 10 years. And when you have sadly a terminal cancer, the discussion with the patient is trying to find a balance between survival, which is sadly a year and a half, versus balancing their quality of life. So we start with why is the overall survival so poor, and over the talk, I'll talk of a few reasons for it. This is how the tumor looks on an MRI scan. You see contrast enhancing tumor, and I put a cartoon next to it. The area of contrast enhancement that you see is what I've outlined in gray. But there's a penumbra zone, which is the sort of white 2 centimeter margin around it, which is where the tumor cells are there. And you will see over the next half an hour of the talk that the focus has always been the contrast enhancing tumor that you see on the scan in terms of surgical resection. So this is what it is. It's the mainstay of treatment. The aim is to try and take out as much of the contrast enhancing tumor, maximal surgical resection, because that correlates with survival. So this is the Oxford data series. This is sort of mid 2014, 2015, our data. What we found, what if you take part of the contrast enhancing tumor out, progression-free survival is 4 months. You take it all out, it jumps to 11.3 months. If you then go into the penumbra zone, which is difficult to visualize on an MRI scan with some exceptions, then the survival goes on to 17 months. So the message is, if you see a scan, try and take out the contrast enhancing tumor because you make a difference to patient survival. But we know that increasing resection improves survival, but the downside is that you should not harm the patient. If they have a neurological deficit, you will reduce their survival. This is a very nice paper showing Kaplan-Meier curves. In red is a group of patients who had a neurological deficit after surgery. You can see their survival drops drastically compared to the ones where there is no neurological deficit. So again, you come back to this balance of trying to preserve function and trying to take all the tumor out. So 10 years ago, this is how things looked like. What was for glioblastoma surgery? What were you trying to achieve and how would you do it? We said we'll use intraoperative visualizing agent, and I'll talk more about it, called 5-amylolevulinic acid. We'll use neuronavigation, which is like a sat nav in theater. But there were some things missing, which we had to look into. Back in 2014, 2018, this was the technology available. We had navigation systems, microscopes, ultrasound, intraoperative MRI scans, fluorescing agents, 5-ALA. Advanced imaging was coming into play. A Cochrane review showed that actually there's no evidence to say any of this makes a difference. So we started early by saying one of the things we have to do is to change the way we look at this by moving from an anatomical resection of tumors to doing a functional resection. So this is how we were sort of visualizing the brain, dividing it into lobes, and said we need to change our outlook from here to understanding the brain like this. This is looking at the nerves within the brain and understanding their function. This is generated from diffusion tractography imaging, which I'll talk about. So this is what it was, functional guided brain surgery rather than anatomical resection where you see a tumor and resect it. The colors are various nerve connections in the brain carrying eloquent function with speech, vision, movement. So the idea was firstly to understand the functional connectome. What is the function of the brain? It sounds like this is quite rudimentary, but we certainly had back then not a very good understanding of the brain. So you started by understanding the function of the brain on the surface of it. And for that, we use functional MRI scanning, where you have an MRI scan as far as the patient's concerned. In the scan of the patient, there's a number of tasks. For example, he's speaking, and you can map speaking areas in relationship to the tumor, because the blood flow correlates with neuronal activation. So where there is more neuronal activation, you pick up the bold signal on a functional MRI scan. You can map movement areas, and then you can also map visual areas. So you got maps like this. This is the tumor on the left side. You see some yellow colors here. This is mapping speech. Patient is doing a sentence completion task in relationship to the tumor on the surface of the brain. And then you get this beautiful 3D picture on the left with the tumor in the red and the yellow functional speech areas on the surface of the tumor. But then you had to understand the nerve connections deeper. The same patient, you see the tumor again, but then you see deeper in the subcortical areas, you see white fiber tracts connecting speech, vision, and movement in relationship to the tumor. So this was all put together by correlating the cortical anatomy with the subcortical in beautiful 3D maps like this with the tumor in brown and the functional map around the area. Now, I'll give you an example how this changed things at the start. This is a 3D map. You have a tumor in yellow. And when we looked at it initially, we said, okay, structurally, this tumor is resectable. Now let's superimpose some functional MRI scan with speech. And suddenly you see these red areas and say the anterior part of the tumor is not resectable because I've got speech. Now you want to superimpose the deep white fiber tracts and you get this. So a tumor where you would have taken out with an initial anatomical scan now becomes a subtotal operable tumor, but the goal is you preserve function. We have access to this in the operating theater. where you see the tumor in brown color. You can see the beautiful tracks around it. You can move it around in any spatial location you like to plan your approaches and how you would access these cases. We then moved a step forward of saying, can we do better and use mixed reality? This is a picture with a patient in the outpatient clinic. And with this, you can show the patient his tumor, the tracks around it. You can talk him through what surgery would involve, what areas are of risk of surgery, what deficits he's likely to get. This is me just showing him this in the outpatient clinic. Most importantly, patient has a much better understanding of what surgery means. And I think the important thing is it's not the surgeon deciding what he thinks is best, but the patient playing an important role in saying, I would like to preserve this function. This is at risk. So it's shared decision making, a completely different concept. It's personalized surgical resection to what the patient wants, not what the surgeon wants. Then you can monitor all this with the patient awake during surgery. Now, this is all very good. We had all this data and we said, did it help patients between that first part of the decade that I'm talking about? And I'll go through a few examples. The first thing was validating functional MRI scans. If the functional MRI is saying that there is speech movement and lip movement on the surface of the brain, is it exactly where we think it is? So with awake surgery, we could actually correlate, as I've shown in some of the pictures here, that where it predicted speech problems, we found them at surgery and lip movement. So very good sensitivity and specificity with functional MRI scan. It also allowed us to change how we approach some inoperable tumors. Traditionally, we said back in medical school, Broca's area was speech generation was inoperable tumors because you would most certainly give patient the deficit. When we did functional MRI scan on these cases, we found that actually in some of these cases, speech was not in the area of the tumor, but around it. So you could actually then resect the tumors. So I think inoperability is defined by your understanding of something. As the understanding gets better, inoperability becomes operability. And this was a good example of it. Then it brought together another set of patients where you had tumors growing within eloquent area. This is a tumor in the motor cortex to do with movement. Traditionally, again, like Broca's for speech, was inoperable. In this case, I'll show you two examples. Functional MRI scan showed actually there is functioning movement tissue within neural tissue within the tumor. So we only did a biopsy, we didn't resect it. Even then, patient had a transient weakness, he got better. So now, if we didn't have the imaging, we probably would have resected or maybe not, and then wondered why the patient had a deficit. A few months later, we had another patient with the motor cortex now in the face area. In this case, unlike the previous one, the functional MRI scan showed that actually there is no functioning neural activity within the tumor. So what then happens is the young patient has an awake operation and you can take it out. So similar examples, but how you approach them is different. One, you've done a biopsy, one you've resected without giving patient a deficit. Just on the theme of tumors within the motor cortex, again, patients who came in with progressive weakness or were paralyzed with tumors growing in the motor cortex, we always had, certainly when I was training, had said, this is because the tumor has damaged the cortical fiber tracts. But when we did imaging, we found actually you could pick up the corticospinal tract. I've written as CST. And so we operated on these paralyzed patients. Traditionally, we never, and this is an awake operation. And she, during surgery, to our surprise, she would start moving her hand. And then post-surgery, we did more tractography imaging and found the tract is again intact. And this is 10 days later. So these patients, traditionally, we would not have operated. Now, two more examples, just to make the point. This is the thalamic pilocytic tumor in the thalamus. You see the contrast-enhancing tumor. You see that a blue fiber bundle, blue and fiber bundle on the deep side of the tumor. So this is post-surgery, and this is how we approach the tumor endoscopically to resect it, and the fiber bundle was intact. A few weeks later, we get a similar case, and we said we'll plan the same approach. We'll go from here. But the DTI showed that the fiber bundle was in the way. So this patient, we did not operate. So same tumor, same location, two different approaches when you look at functional imaging. If you look at abstract anatomical imaging, you would operate on both and give patient a deficit. Then we moved on to next complex. You had complex tumors like this, where the tumor's in red and you have fiber tracts surrounding it everywhere. It allowed what is called an interfascicular approach, a new concept where you would go in between fiber bundles to try and resect them. Again, one more examples, a musician, he was keen on having his ability to read music and obviously play the flute. He's playing it there and preserve his vision. Again, done awake with imaging to preserve his function. I'll mention the last example before I move on. Historically, we said thalamic tumors deep were inoperable, high neurological deficit because they were covered by these blue fibers, which were movement. But what this allowed us to do was to choose. I'm going to move this video, may not play. We started using endoscopic minimally invasive approaches to try and access these tumors through a small access corridor. This is the post-operative scan, which shows the trajectory, but you see the blue fiber bundles are preserved and the operation was done without any deficit. My last bit, and I think this really was revolutionary for us, plasticity. We heard a lot about it. We talked about it. It's there around everywhere. Young patients with tumor and speech around it, imaging showed had an awake operation, and we ended up leaving tumor close to the speech area and did a follow-up functional MRI scan. And what we found was this patient had no speech on the left side prior to surgery, but because of plasticity and rewiring developed speech on the opposite side, which means you can then all go back on the right side, remove the tumor because you know there's compensatory speech on the other side. Now, the question then came with the examples, and I can go on and on with these examples. What is the sensitivity, specificity of all this that we are talking about the functional imaging? This was the paper we published on our first 100 cases where we correlated the imaging with the awake operations. And this is what it showed. The accuracy of different tracks, and I won't go into detail, was very high. Now, we then said, now we are understanding the brain function much better. However, are we visualizing the tumor better? And that's where 5LA fluorescence with glioblastoma came in. It's an oral drug you take an hour before surgery. It gets taken into the tumor. It goes through the Krebs cycle. You shine ultraviolet light at a wavelength of 405 and 330. It hits the protoporphyrin 9, and then you get fluorescent light reflecting back, which gives the tumor a pink color. Very nice trial done in 2006 by Walter Stummer's group in Germany, multi-center trial, and he showed that actually using 5LA versus white light made a difference in progression-free survival. This is what it looks like. This is how you would see a normal tumor during surgery, where it's difficult to differentiate it from surrounding brain. And then you switch on the blue light, and I hope you'll see it. You see a pink fluorescence coming through. I don't know. I don't think it projects very well. You can just about see something there. But this is what we started using, and NICE made it standard of care in 2018. So two things. We went from understanding the brain function better. We could see the tumor better as well. However, we weren't sure whether we're taking it all out because the cavity is never uniform. The brain cavity, it's got sort of sulci and crevices. You can leave tumor behind without knowing. So we then did work on intraoperative ultrasound. It was available. The quality was very good. This is an example in theater. You see the tumor. This is an ultrasound viewed with the MRI. You see live resections of the tumor, and that's a complete resection. So intraoperative ultrasound is a very good tool where you could monitor your resection live. Now, so we went back and said, we understand the brain better. We can see the tumor. We think we can achieve a complete resection. So now the question was, how do we bring this all together? So this is what I started off with when I said initially we had this 5LA. We said we'll use navigation, and we didn't know what this was. So we then put together three pillars. We said use the 5LA because there's nothing better at the moment. Instead of using standard navigation, we look at the brain as a function and look at diffusion tractography I've talked about. We'll add a third pillar. This was the triad of intraoperative ultrasound. But the question then came about, is single-centered data enough to change clinical practice? So a survey in 2018 across the country, 24 neurosurgical centers, not surprisingly found variability in the extent of tumor resections. The concept of complete removal of tumor was not always there among all centers. The adjuncts used are very different. So there's wide variation in practice. So at number one, at this point, we put in an NHR application with colleagues in Imperial, and they funded this trial, which is presently running called Future GB, which is functional and ultrasound guided resection of glioblastoma. So the question then was, if you have so much variability around the country and you want to make change, how do you ensure standardization and quality of what you're proposing to make sure that the results are what you want? So the trial is all across the country in these centers. So with Peter McCulloch, we designed the trial in 2 stages. We said, if you want to ensure standardization and quality, we need to implement the ideal principles within the framework within the study. And we chose the stage 2B at the initial starting phase. And we said that any center going into the trial will have to do 3 to 5 cases. Industry would support them with the latest software and hardware. We would ensure there's standardization of functional imaging. With DTI, how imaging is required, the physicist pretty much at every center tried to standardize the acquisition of imaging. We standardized protocols for how ultrasound would be used during surgery, specified time points at which would be used. We then specified how the intraoperative workflow would work, how data would get transferred, which included all the DTI functional imaging, all the intraoperative ultrasounds to Oxford and Imperial helped the ultrasound data analysis. So this was how every center went through, and obviously there was mentoring, regular coaching sessions with PIs and other with us in Oxford and in Imperial, online symposiums. So after every site went through a level of standardization, they are now going to the RCT, where the difference is the intervention arm gets, in addition to standard of care, which is neuronavigation and the fluorescent dye, DTI imaging and intraoperative ultrasound. A host of outcome measures, but this is the first surgical neuro-oncology trial which is focused on patients' quality of life with a novel measure called deterioration-free survival, which is a combination of quality of life and overall survival. And lots of tertiary outcomes, including, because it's EME-funded, mechanistic with DTI and ultrasound. So number of trials, saying there are 17 sites in stage 2, a few more in stage 1. And this is where we are with the trial. We've recruited 71%. I think we've asked for a 12-month extension to complete our recruitment. So back to the diagram, and Future GB looks at addressing this enhancing entity, not the penumbra zone, just this enhancing intensity, to see whether we can raise the standard of care across the country. Then the question is, what do you do with the penumbra zone where invariably the tumor comes back? And then you go back to the drawing board and say, what tools do I need to resect the penumbra zone? Because that's where you're going to make a difference, because that's where the tumor will come back. And I'll talk about 2 works. James Livermore, a DPhil student, did work on Raman spectroscopy earlier on, where we first started with ex vivo work with samples to see whether the technique is works, and found that actually it's got high sensitivity and specificity to detect tumor margins and the penumbra zone. Then the obvious next paper was to look at the comparison with 5LA. If you're going to push the boundaries and say 5LA, because 5LA looks at just the enhancing bit, you want to look at the penumbra zone. We found that the sensitivity, specificity, and accuracy of Raman in the penumbra zone is much better than 5LA. So actually, you can then go into that area to analyze the tissue. The limitation, and I've just summarized here with application, has been the spectrum is very variable, and you need to standardize a number of parameters to get a reliable spectrum. So, and it's been a challenge doing this. So this work, we sort of, I would say, put a stop to it because it's difficult to translate it intraoperatively in theater. So this is where Raman spectroscopy came in with surgery. And now we've got funding from CRUK to look at mass spectroscopy using the ASAP mass spectroscopy technique. We just got ethics approval to start work on this with ex vivo samples initially, but pilot data is good. You can differentiate glioblastoma, normal white matter, and the work will then continue here, as we've said, in an initial sample size of 20 patients to see whether it is sensitive, specific enough to pick up tumors within the penumbra zone. So that's where mass spec goes in. Now, I'm going to change tack from tumors and move to downstream below surgery in the management of glioblastoma. And I've put in there immunotherapy trials. Immunotherapy has sort of revolutionized cancer treatment in the past decade, if not longer. And a lot of the work started with what we saw with melanomas. We saw immunotherapy with PD-1 and PD-L1 inhibitors. The overall survival of melanomas increased significantly. And then, as would be expected with other cancers, immunotherapy was tried for glioblastoma as well. And when immunotherapy was first tried, the ethics was granted for trials to only use it when there was a recurrence rather than as a primary entity. But the initial trials which were completed showed no benefit at all. And there are a number of trials running at the moment, but all of them, if you look on the right, says all for recurrent glioblastoma, not at primary diagnosis. Now, why did the trials fail? The trials failed because of a few reasons. One was the overall mutational expression of glioblastomas is low, which means the immune response is likely to be low. Second is you have a very immunosuppressive microenvironment around the tumor bulk. And third thing is there is marked tumor heterogeneity within glioblastomas. So Rui Chong Ma, who is presently our NHR ACL as well, did this PhD with at the Weatherall Institute with the late Professor Cerundolo, trying to understand this more. And we came up with this some conclusions here. Immunotherapy is linked to mutation and neoantigen burdens in cancer. Tumors which have a high mutational or neoantigen expression, like melanomas, for example, respond very well to immunotherapy. And I've sort of put in the red there at the bottom, which is where GBM set. And obviously, within GBM, tumors which had a higher expression, because there is so much heterogeneity, those patients live longer. So this data was on 116 patients from the American Cancer Registry, showed survival correlated with mutational burden. So how did we increase it? The work he did in the lab was we're looking at decitabine, which leads to hypomethylation of the genome. We saw increased neoantigen cancer-resistant antigen expression, led to increased immunogenicity of the GBM cells, and those T cells showed increased killing of the neoantigen expression. So that was all good. But the question was, again, it goes, can we translate it to the bedside? And so this was what the immunotherapy trials had done, and we shifted the focus slightly to this. I put in there combat GB, which is neoadjuvant. What we found was if you're going to make a difference to increasing neoantigen expression, you need to do it before you resect the tumor because the mutational burden is likely to be higher. So Combat GB then got funded, and I think we'll recruit the first patient hopefully this month in March. Is a combination of Aztec 727, which is decitabine, and nivolumab, which is an anti-PD-1 for the treatment of newly diagnosed glioblastoma. So this is a phase 1 window opportunity multicenter trial, first in man trial. Neoadjuvant immunotherapy for GBM has never been done before. And this hope we do to do it in 30 patients. There's slight uniqueness with this trial where normally you would see a patient in your clinic and you would offer them surgery. We've sort of put this neoadjuvant part where immunotherapy comes in. This is what they get, their drug prior to surgery. However, to try and understand the change in methylation, the neoantigen expression, and tumor infiltration, we've added an experimental biopsy. So patient would have an experimental biopsy, then have the drug, then have a resection. The idea is to see a change in the tumor with the biopsy compared to resection before and after treatment. Obviously, this is not compulsory as far as the trial is concerned. So the patient doesn't consent to it, then they would still get the a neoadjuvant treatment. But hopefully, if some patients do, then it will give us a lot of information of how some of these things change. Again, novel, never been done before. So this is how the tree is now looking. And then this is a problem in the sense that glioblastoma will always come back. And the evidence becomes very thin. What do you do? At the moment, we offer them second line treatment, which the response rate is about 10%. Then the whole role comes around. Is there a role for further surgery with these cases? So this is a tumor you see on the right side, how you resect it, complete resection, no residual tumor. And sadly, 9 months later, the tumor is back there. This is the evidence from a number of cohort studies over the years, which have looked at role of surgery for recurrent GBM. And they've said, well, there's some benefit of a few months. And this is our own data. This paper got published this month, looked at about 432 patients to see whether repeat surgery makes a difference. Now, this is the Kaplan-Meier survival data. And what it shows that if you have one operation when you were first diagnosed, your median overall survival is 13 months. If you have a second operation with recurrence, the overall survival goes to 22 months. If you then have a third operation as a section, your overall survival goes to 44 months. Now, obviously, this is retrospective data, patient selection, there's a bias here, but it sort of gives you an idea that survival does improve more you operate on the patients. But the question then is it applicable? Now, there are presently 2 randomized trials looking at this, but they've been running since 2015. And critical analysis of the trial, there are a number of unanswered questions within this. And the key one is quality of life. Most of these trials look at overall survival, but that's not patient facing. Quality of life is what needs to be done for something which is terminal. Extent of resection and other questions about early versus late recurrence and what you do. So this is what we proposed to NIHR for a trial called Recurrent GB to look at the role of a multi-center trial, to look at the role of resecting these tumors and to see whether it really makes a difference to what we can do in terms of extending overall survival, important in quality of life. So I go back to this chart again, and this is where a recurrent GB sort of slots in there. Now, this is where we are with neoadjuvant therapy for our combat GB trial. Future GB is looking at the role of surgery. Raman spectroscopy, as I said, I don't think is going forward with the work we've done. And mass spectroscopy endoscopy is looking at some of the penumbra zone and better surgical resections. And recurrent, hopefully, with funding, will look at the recurrence and what one does on these cases. So it's taken us 10 years to try and move up the level of evidence to see whether we can change practice in this and improve the overall survival of glioblastoma. And I think I probably will have the answer in a few years in the next NDS grand round to see whether we made a difference or not. There are members of the team I would like to thank, our DPhil students, our present academic CLs, clinical lecturers, host of other collaborators, and then NIHR and other sponsors who've been very kind to us. Thank you very much.